Ed eccoci qua di nuovo, bentornati al...
Here we are again. Welcome back to the vision stage. We are inside an event that is fully devoted to eye care. And it seemed to us it was a duty to devote this space to vision health in pediatric age. It's one of the most cross-cutting themes in eye care. We have various factors today, just like the increase in myopia and late diagnosis of visual defects, management of strabismus and binocular vision disorders, and new digital lifestyles. And you have a rethinking of management models, diagnosis, and taking care of young patients. And the focus of this meeting is this, creating a space for an exchange oriented to practice and establishing a dialogue between different professionals of the sector. The event is promoted by Commissione Difesa Vista, Fabiano Group Editoriale, and B2IC magazines that have been working for years to disseminate a culture of visual prevention. And we've tried to make this meeting as dynamic as possible to foster dialogue and listening. We have 2 moments. Institutional session devoted to scientific evidence and models of collaboration, and a second session devoted to best practice to try and understand how we can translate into practice the experience gained. And let's start with the new institutional contributions. In this stage, you have one of the highest level representatives of the medical world and optical world, Professor Paolo Nucci, president of the Italian Ophthalmology Society, Professor Rino Agostiniani, president of the Italian Pediatric Society, and Andrea Afragoli, president of the National Federation of Opticians, Federotica. Welcome. We have so much to talk about. Let's start immediately by giving the floor to you, Professor Nucci. Let's try and draft a general picture of the scenario. How is the epidemiology of visual defects in developmental age evolving? Which are the main problems? Allow me to extend my thanks to Astrid. I've known you for some years now, and we started quite early. Commissione Difesa Vista was a reference point in the first years of my profession, and you were extremely young, and I was a bit less young. But thank you for having me, because I followed Simone in 8-9 things. He can manage it all. He's not the usual actor, is the right anchor man. Very kind, thank you. And after this captatio benevolentia, I don't know if you've gotten bored of listening to me, and I spoke so many times in the past. I'd like to tell you something immediately. First of all, those operating in pediatric eye care are considered to be heroes. You have you don't have enough pediatric ophthalmologists. It's a pity because senior professionals are about to retire, and we need young people, and we don't know how we can entice young eye doctors to act in this field, and you have the importance of prevention and orthoptists. We as physicians cannot meet prevention demand. Orthoptists are fundamental, and optometrists are as important. And I'd like to have optometrists working in hospitals outside commercial structures, just like in the USA, in hospitals. And I'd like to give you good news. Professor Agostiniani, president of a society. My society is small, but his society is big. A pediatrician, Italian society. He had contacts with the Ministry of Health, and he will prevent the problem of myopia. The problem of myopia up until short ago was not considered to be a relevant problem, and the ministry entered in touch with you, and so the interest toward pediatric eye diseases is high, and I'm in the final phase of my profession, but I'd like to see a world, the opening up of a world of ophthalmology. The weight of an eye is 7 grams, and you know, do you know how many specializations you have in ophthalmology? 13 of them. Those dealing with the orbita, vitrium, and vitreoretinal surgery, cornea, and so on and so forth. 13 sub-specializations, and it's so interesting. And those that are active in the field of pediatric diseases can manage so many diseases and problems. It's an extremely enticing, exciting area. I have a small patient sitting in the corner. Some patients, and they love me. They follow me everywhere. It's a realm where human satisfaction is extraordinary. I invite you to ask young people to be interested in the sector and pediatric sector. This is a nation where a child is born and is entrusted to a doctor. There's no relationship in the world where you have this privilege of being entrusted to a physician, and this system is fundamental. And I will listen to the various speakers, but then I have to go away. And pediatric diseases cannot be neglected. Sorry, Simone. It's a very good introduction to understand what the state of the art is today. We have orthoptists helping us a lot, and for many years I was president of the orthoptic university degree, and I'd like to have in the course an optometric figure trained by us, because we have patients. We can share patients with the optometrist, and I'd like to have a medical university training for orthoptists. I strongly believe in it, and main critical issues. It's very few of us, and perhaps it's the least remunerative of a remunerative profession. When they ask me why all young students want to study medicine, I come from a generation, and you chose to become a physician because you read Cronin, Chekhov. You had an idea of the general practitioner that went to a village solving special situations, difficult labor, and present generation. If you think that the 3 specializations most opted for dermatology, plastic surgery, and eye care. In my generation, there was a sea change in Italy. The famous Basaglia law and lunatic asylums were opened, and we were in a heroic age. In 78, the national health system, in the wake of NHS, we were the pride of the system in Europe. Is it like this, Rino, now? He spoke like a boomer, as I am as well. I can keep on. We have a system that deserves to be protected. and very often we cannot really understand the scope of it in terms of equal access and presence all over the national territory with its distortions. And we are getting off topic. And I ask you, considering the new digital models, how has the figure of the pediatrician changed? Well, first of all, the youth generation has changed. It's a first element that we should consider when Paolo spoke about the contact between us and the ministry. And, well, that contact was established because we need to set the emphasis on the explosive evolution of the digital world, and it has repercussions on the youth, starting in the early period of life. Then I will speak about myopia, and we should consider that an early use to prolonged use of a digital instrument changes the growth path of a child. A typical example, if I use iPhone as an instrument to keep my child under 2 years of age quiet, this causes a delay in language acquisition. And for example, if I use it for a too long period of time in subsequent ages, there are studies showing us that all of this changes the structure of the cerebral cortex. And I usually give an example with sports. If I train a specific function, those muscles grow more than the others. The same thing happens in the brain of the youth. If you want a clear example of epigenetics, try and see how a young person manages the cell phone. He uses thumbs, writes with thumbs. I cannot write with thumbs. It seems strange, but it's real epigenetics. And today the youth have an ability that today we don't have, and it was acquired in the course of 10 years. And think how we could change in 10 years just for the use of a cell phone. When I want to mock them, I tell them that the most developed muscle is the flexor of the thumb, and they should develop other muscles for a better quality of life. And now myopia and spending a long period of time in a context of focus at near, just like in the case of smartphones, eye doctors know it. This is an impact on development of the eye that becomes a bit too long. And in some Asian countries, for example, it's an epidemic. 90% of youngsters, and apart from personal genetics, what you do, and so people suffer from myopia, what you do in terms of lifestyle has an impact, and something that pediatricians should do, explain correct lifestyles. The more you stay outdoors and the more you use your vision from far, and the better the development of that organ of 7 grams. And can I ask you, if parents listen to you, well, such things should be explained well. And it's obvious that you cannot start from the assumption that a parent uses the cell phone all of the day and then tell their children you cannot use the cell phone at dinner and after dinner, whether they have common disconnection moments or it's unthinkable to change the habits of young people. And you can achieve changes by example. An adult should be a credible model. If you're not a credible model, your child will never consider your words. Yes, it's true. On Sunday, you should go out for an outing. The problem is not banning something. You should identify alternatives. I'd like to end with a quotation. Thomas Mann told his father, stop with words, give an example. And sorry, I have to leave. Thank you so much, Professor Nucci, for staying with us. Goodbye. Let's now get to Afragoli. Here we are. I wanted to ask you something about the role played by an optician optometrist in an integrated approach. I like to think that a child, apart from the role of the pediatrician, and we appreciate the role of pediatricians as parents, a child should be followed by an ophthalmologist, physician, to exclude certain diseases. In the first few years of life, the system is formed. If the system is not formed in the correct way, you're lost forever. And it's fundamental to follow this type of approach. In the first few years of life, with the exception of special cases, I could mention some examples. In the past, I happened to see a very small girl, the daughter of a myopic client, and she told me, Andrea, can you examine the girl? And I said, she's too small. And she insisted she had a binocular cataract, and it was secondary to diabetes. And from something that had not a big value, there was an incredible scenario. It was a small spark. And in a context just like Bologna, where I come from, and it was a well-off family, and there was everything necessary whereby the child could be followed by experts. This approach is fundamental. Something different is adolescents, 12, 13, 14-year-old teenagers that perhaps want to wear contact lenses, and during a myopic evolution, they have the need to follow a certain path that can slow down a myopic evolution, and our role becomes central and important. Why? Because we have certain tools to make available, and effective instruments as well. And I'd like to remind you that as a trade association for various years, we've had a project called Bimbo Visione. It doesn't consist in specific operations on subjects. We do not perform screenings, but we speak in schools about visual defects and typical problems, and we create awareness and information for such young subjects, for students specifically, and parents and teachers. Information necessary to have a deeper knowledge of visual defects, and it's something we are extremely proud of, and it works perfectly. And we're very happy about it. If we should summarize everything and focus on a critical point and something urgent to work on.
What's your take on that? Well, from the point of view of the pediatrician, so we are talking about prevention, diagnosis, early diagnosis. Well, the pediatrician, like Paolo said, is fundamental because when a baby is born, there is a pediatrician for him or her. That's important. So if the pediatrician works well, as is mostly the case, well, this consists in accompanying the family in the healthcare journey of the newborn. So in terms of prevention, what do we do? Well, we already talked about that. First of all, educate to proper lifestyles, not only for childhood, but also across the lifespan. We're fully aware that most of the disease has an impact on the health expectancy and health span, but mostly it depends upon early childhood. So we have to provide advice in terms of behaviors for prevention purposes. This is certainly fundamental. One more aspect is to structure mechanisms so that we can have an early diagnosis when the problem is found. And I believe that pediatricians can evaluate the visual acuity of their patients with tests. And a 3-year-old can also have fun if you do a test for visual acuity. And if you repeat that once a year, you're capable of identifying those who will need specialist skills. But, well, in the meantime, you will have done an early diagnosis and you will have accompanied the family throughout the journey, providing advice in terms of strategies that can slow down the progression of the disease. There's not much awareness of parents to understand the difference between the lenses to improve the defect or the strategies that can be used so that the progression of myopia is reduced or limited over time. And I believe that the pediatrician's role is extremely important because if you are the one who takes care for the first time of the newborn, well, quite clearly there is a special relationship and you are the go-to person. I've spent several years as pediatrician and I have former patients who at the age of 30 ask me, I have this problem. There is a trust relationship that continues over time and that has been nurtured over the years. And personally, I believe that you're glad of that. Yes, of course. It means that you have worked well. Luckily, I've never had to wear glasses as a child. Can I ask you, what are the first warnings that the parent can see so that he or she understands that the child has problems? Well, if the parent realizes it means that I didn't work well. So first, a pediatrician. No, that would mean that this early diagnosis and prevention hasn't been done well because more often than not parents realize when their children go to school because they may have difficulties. And it can be a learning difficulty that is rooted in a real eyesight difficulty. Or maybe, to watch the TV, the baby gets closer to the TV set. And these are warning signs. But if you do a test, an eyesight test at the age of 3, you can find this problem. That was a curiosity. But again, go to the pediatrician who will take care of this. Yes, of course, then maybe we'll come to that later. But there is something that we call bilanci di salute. So on a cyclical basis, we evaluate the growth of the child, and as part of that, we evaluate an early onset of an eyesight defect. And that's part of it. Likewise, we will also try and educate the parents on the use of digital devices. Thank you, very clear, Professor. Fragola, would you like to add something on that? Maybe there should be a match? Okay. Like Professor Nucci said earlier on, ophthalmologists, pediatric ophthalmologists are not so numerous, and this will be the case in the future as well, because probably the profession is not so appealing, even though it would deserve to be appealing. This is a specialization within a specialization, and this inevitably means that these children, other than the role of the pediatrician, which is an important role, well, should be managed by multiple professionals who are not represented on this stage, including orthopticians. They do have a role. We find them in hospitals because most of them work in hospitals, and orthoptists deal with binocular vision as well as more than that. So let's say that other than the role of pediatricians, these three categories that represent us, that represent the eyesight world, should come together and converge for the benefit of the families of these children and babies who need to be managed at best. I mean, I'm trying to be simple, but what we're looking for is dialogue. Sure, and hopefully there will be more and more youngsters who, at the time they will have to choose what university to go to, they will choose this profession. Like you said, maybe this profession is not so appealing. Pediatric eye surgeons, this is the category I refer to. A couple of things. I'll start from the second. Well, quite clearly, I see the pediatrician as the person who can be the go-between, emphasizes the problem and then refers the patient to the specialist. And this based upon the numbers. I mean, we can think that all children can be visited by a specialist. So we need to do a good sorting of those who have important issues who will have to be assessed. The other comment is about what Paolo talked about in terms of the fact that few eye surgeons want to specialize in pediatric ophthalmology, but this applies to many adult medicine specialties because children at times are annoying. You know, if you tell an adult, do this, do that, the adult will do that. But the children, you have to chase them at times. So if you establish a good relationship with the child, if you love this profession, it's very rewarding. But if you want a visit to last only 10 minutes, no way, no way. With children, you can't do that. You can't have a tight schedule with children. No, you need to be elastic, but it's so rewarding. Sure, first of all, a big hand. We'll meet very shortly, but thank you for your clarity. And now we can move to the best practice. We'll be on stage again shortly. So from theory to practice, we've been talking about models and responsibility and collaboration. Now let's see how all of this can be translated into practical and replicable experiences. So now we have with us Professor Aldo Vagge, Associate Professor of the Genoa University, Head of Pediatric Ophthalmology of Ospedale Policlinico San Martino, Dr. Pilar Nannini, pediatrician, Dr. Anna Lucia Lauria, orthoptist and member of Difesa Vista, and Dr. Stefano Bernabei, optician owner of Optikid, the only one in Italy specializing for children and youngsters. A big hand to welcome them all. So start from cases and real examples so as to offer insights and food for thought that can be immediately applied to everyday life. We'll try. Professor Vagge, I'll start with you. We've already talked about the scenarios and criticalities connected with eyesight effects in the developmental age. So let's move to practice. How can we manage the myopia progression, and which are the best practices? I know it's complicated. The journalist Marzullo would have asked this question. It's so complicated. Well, according to me, we've been talking about sharing, and sharing is fundamental. We've seen the different roles, the pediatrician, the orthoptist, optometrist, and this, according to me, is fundamental for a proper care of our patients. And then, quite obviously, we have to consider that as of today, there is scientific evidence proving that some strategies can be effective in reducing this progression of myopia or even prevent it. So we're talking about primary and secondary prevention. And this because there must always be more awareness of myopia, which is not just an eyesight defect. It's not just a pair of glasses. But in fact, we know that myopia is increasing. There's a famous trial that is well known and says that 1 person in 2 will be myopic within 2050. Maybe a bit less so in Europe, but it's a massive number. And if this is the case, there will be also pathological myopia increasing. We're talking about 50 to 75% of highly myopic patients, and this is a fundamental condition because it is the main cause of blindness and poor vision. So it's correct not to alarm people, but we should be aware of the fact that myopia can become an eye disease proper. And so we all have to work together and have an organization allowing us to support these patients and recognize who amongst them can be myopic, and we can also consider some patients who are becoming myopic. And we are talking about pre-myopia. We need to be able to identify those patients who are not yet myopic, but who have risk factors and who have a high likelihood of becoming myopic. And to do that, quite obviously, eye surgeons cannot do that alone because, like we said earlier on, we can't believe that the screening can be the responsibility of eye surgeons, most especially within hospitals. We have too many patients, and we have longer waiting lists, and the screening is for a healthy population, or, assumed to be healthy, at least. Quite obviously, according to me, we need other professionals like orthoptists. They're fundamental. But this is fundamental for the screening because this can identify the possibly myopic patients, and 15 to 20% of these patients, when screened, turn out to be myopic or turn out to have another eyesight disease. We often talk about high tech, but what is the most useful means that we have to identify a patient who requires an eye surgeon visit? It's visual acuity. If it's not 10 in 10, the patient needs to be analyzed by the eye surgeon. Otherwise, this patient may be hypermetropy, but it's a patient who's healthy, and that's fundamental. And that's reassuring. And we always suggest a test once a year, every 3 years, every 5 years, to dilate the pupil and see the retina. But the screening activity is fundamental. So, a virtuous method. And then, going back to what I said about scientific evidence, today we have possibilities in terms of reducing the progression of myopia up to 55% in the long term. We're talking about efficacy. And, well, this has been proven as long as at 8 years. So we can't do without that, according to me. You've been very clear. And we are talking about practice. We want to talk about the best practices to understand how to handle this in practice. So let's say that, according to me, the best mechanism is the following. We should do a screening, and, well, the pediatrician has a very important role, and there should be standard screenings at school to identify at-risk patients. These patients must be visited by the eye surgeon, and the eye surgeon somehow will do a complete evaluation and will identify whether or not these patients deserve a strategy to curb the myopia progression, because, like we said, not all myopic or apparently myopic patients need to be treated. We only act, and this is a key message according to me, on axial myopia, that is to say, the one that is characterized by lengthening of the eye. As for all of the other forms of myopia, like those due to the sphericity of the cornea or the spasm, these are not forms of myopia on which we can act, because the question is, why do we act on a myopic person? Because don't want the length of the eye to go beyond a certain value. This is what is associated to an augmented risk of myopic glaucoma or macula. Conceptually, how can we identify this? Well, with optic biometry, i.e. measuring the length of the eye. And this length should be set against the percentiles of growth. Like pediatricians, they use percentiles of growth to understand the height and the weight, and you name it. Likewise, we have our own percentiles indicating whether or not that eye is growing beyond the average and by how much. And so, to be practical, we start to treat the patients with an actual length exceeding the 51st percentile. Thank you, Professor.
I pediatri
You spoke about pediatricians. Now we give the floor to Dr. Nannini. And I'd like to ask her how you can build a trust-based relationship with the family to guarantee continuity of care in the course of time. Thank you so much. It's a difficult question because we dig into the depth of our activity as pediatricians. Just like was said before, each child, as soon as the child is born, is entrusted with a pediatrician. The pediatrician is the person that gains the trust of the family, and the pediatrician should educate the family, speak openly with the family about the various developmental steps of the child, and speak about screening instruments, and also in terms of sight, the pediatrician is a reference point for the family. That's the reason why we shouldn't just be good at explaining and speaking, but we should also be good in our relationship with our colleagues. We are the link between the family, the child, and other colleagues that will manage the child when necessary. And thanks to this trust, in the course of time, we can do precious job for early screening. And apart from cooperating with reference figures, ophthalmologists and eye doctors, we should also thank all the entities and associations present all over the territory, because they allow us to make an early diagnosis, just like the association Occhi di Bimbi, and we can carry out precious screenings and going into squares and raising the awareness of the population about early screening. I like to mention an African proverb that perhaps you know. It's representative of the figure of the pediatrician. If you want to be first, you run alone, but if you walk together, you can go far. That's why pediatricians are entrusted with this competence. I see so much passion in your eyes, and it's great. It's a great honor. Your children are lucky, but I see you so passionate and involved. It's quite normal, because when you treat children, you may have special cases. Yes. I consider myself to be lucky because my profession is based on sacrifice, but just like most colleagues, and just like Professor Agostiniani said, I'm part of that generation that grew with the idea of an old-style physician. A physician has a burden of responsibility on their shoulders, and this makes us grow quickly, and especially at the university, when our friends are out having holidays. No, we read books day and night, and that's the life of a student of medicine, and so much passion, and translated into practice to the benefit of others. It's the engine of everything. Less vacations, but okay. Thank you so much, Dr. Nannini. Dr. Lauria, good evening, welcome. And I ask you what most effective practices are in terms of prevention in pediatric age. And we should shed clarity, because the practices that we can use in pediatric age, well, they should be early, accessible, and agreed upon early. Why? Because whatever we can fix from 0 to 6 years of age, it's what is defined as plastic age, and whatever gives us a sign, a warning sign, during that age bracket of children, well, a warning sign is useful to help the child. An anomalous position of the head, if the child gets close to the TV, for example, and at school, if the teacher speaks about anomalous behaviors. And why should it be accessible? And it's what Commissione Difesa Vista does, going into squares and giving everybody the possibility to participate in visual screenings. And we are always present at various events, tennis and friends, and so on and so forth, so many events. And during such events, we give parents, but also adults, the possibility to come with their children, so that we can screen children, and also schools And what do we see during screenings? Some children perhaps have been seen by an eye doctor, but other children are a bit less lucky, and we give them the possibility to be visually screened. And then obviously the child is referred to the specialist, and also the curiosity of parents. For example, at the end we give a gadget, and we can visit the child, and then sharing. It's something that should see us all involved during screenings. It's teamwork. You have the optician, optometrist, orthoptist, the eye doctor, to, in a way, attach more importance to screening. And at the end, we bring home a good result and so many emotions. That's good. Thank you so much for your contribution, Dr. Bernabei. Last but not least, in order of importance, the optician is the last. We are the last link in the chain, and we have to translate the investigations of the eye doctor and orthoptist. We have to translate it all into eyeglasses, spectacles. It's a big responsibility. We are last, but the work done by previous people can be destroyed if we do not do our job well. And it's important to use same type of language used by other professionals when we communicate with the family. Sharing is a key word at this conference, and it's important to use common language altogether because it's the only way for families to understand the importance of the message that we want to launch. After eye doctor visit, optic visit, after the optician has made spectacles, then you should convince the family that it's important the child should wear spectacles. And if we do not act in a uniform way, the family may not be fully convinced of the actions taken. And in my job, very often I have an exchange with the eye doctor or optist, and both of them, perhaps because eyeglasses should be the result of what was decided by previous professionals. Yes. That's good. Thank you so much, Dr. Bernabei. And we've listened to different types of experience, but in common they have the same professional approach, obviously. And before giving the floor to the audience, if you should indicate a specific element that really made a difference in your way of working, integrated way of working, which one would you choose? Difficult. It's a difficult question. Yes.
Che per la condizione, allora.
As for the field of diseases, it's myopia, because thanks to myopia we could cooperate more and more. Myopia is the word. And my colleague, the optician, wanted. I want to stress a concept. You don't have an activity where somebody comes last. Each one of us is fundamental for the final result, which is our patient. And if you don't have a link, everything it vanishes. You must have a lot of communications, yes, because you need to communicate and use common language to attain our objective, that is to say, patients. Please. Oftentimes, when a child goes to an optician to choose eyeglasses, the optician has a double capacity and should mediate between the parent that wants wonderful eyeglasses and his professionalism that should suggest technical eyeglasses. It's a very important link because if you listen to parents, some technical details are gone lost. We're here to stress this point. When we decide the type of spectacles for children, we should be more technical, and because it's also a question of fashion. Yes, that's the problem. They do an important job. When we deal with children, it's special clients because it's just as if in creating eyeglasses we had three clients: parent, child, and the physician. And sometimes also grandfathers and grandmothers, and and also the orthotist when spectacles should have specific features. So it's not easy to meet such three different requirements. If the family doesn't understand it, the family doesn't understand why spectacles should receive the approval of the physician. And so we can have good-looking spectacles, but also functional spectacles. Explanation is the word, yes. Explanation. That's good. Doctor? We as pediatricians have basically two instruments. The first one that helped me a lot, autorefractometer, and you can be quick in the decision-making process. It's a reason to be satisfied, and then the other fundamental instrument is empathy. I will always remember that I had a small patient, early diagnosis of myopia, and she had to wear spectacles immediately, but when they placed spectacles on her, there was a rejection. I tried to be in the shoes of Matilde, and I told her, Matilde, do you know that your spectacles are magic? She saw the world with different eyes, and we have established an alliance that goes on, not just with me, but with all the specialists. We need some magic. Otherwise, if everything is too serious, and especially if you have problems during childhood, you need magic and your human approach. Fragoli, there is, if you can come back to the stage, and at this point I give you the floor if you have questions.
Sì, vedo una mano. Aspetti, le porto un microfono, così se gentilmente la regia mi accende questo blu, così lo possiamo sentire. Grazie.
È stato tutto perfetto. Sono un ottico optometrista.
Everything was perfect. I am an optician optometrist, and the cycle doesn't end when the child goes to an optician and spectacles are made. The cycle begins again because this child should be accompanied in the course of time. And when the child becomes older, once we have solved problems, the patient might want contact lenses and so on and so forth. And you should explain why spectacles are used and how they should be used, but also contact lenses. And so our function goes on, doesn't end. For all of the life, I'm an optician, optometrist. Why haven't we invited you? Do you want to get onto the stage next year? That's how it is.
Grazie, grazie a lei, allora buon lavoro. Abbiamo altre domande? Sì, vedo 2 mani alzate, eccole lì.
You go first. I fully agree on the autorefractometer. That can be an instrument that can put together opticians and pediatricians, because many opticians do have this instrument when they have to work on a refraction with a patient who's bedridden. So you use this instrument. So the pediatrician, if the pediatrician knows an optician with this instrument, could use this instrument instead of the other colleague. In the US, this is very much widely used, and Enrica Ferrazzi, in her screening work, uses it a lot. It is an instrument that, on average, and tell me if I'm right, can detect up to 15% of people who've been screened and who could have an eyesight problem. That's absolutely true. Just one comment. Remember that it's not only refraction. For example, you could have a refraction of +2, so an absolutely normal condition for that age, but you don't have 10s because you have an eye disease. So refraction is fundamental, but it's not the only condition that we can and must analyze. First of all, congrats to all of you for this talk, most especially to Dr. Nannini, for emphasizes empathy, which is the key when it comes to patients and clients. So congrats. And then I have a special question for Dr. Bernabei, because I'm starting, a pediatrician's journey. I have an optician store, and I would like to become a point of reference in my area, like you are with your store. But I'm meeting so many barriers. Brands propose frame. We have many models for adults, but only very few for children. They're nasty and difficult to sell. There are companies like Centro Stile that do beautiful frames, but that's a barrier. And then the fact of getting a foothold in the world of eye surgeons, there's a barrier. Can I come and see you? I have this project. No way, no way. Always a barrier. So I want to ask you how you've pulled down this wall. I think that this question is useful for all. Thank you. It certainly is. Well, first of all, I have no lessons to deliver. Let's say that I have had the good fortune of being here, because over the last 22 years I've only worked on children. If you had asked this question 22 years ago, probably my answers could have been different. But let's say that the first thing you have to work on is connected to what you have perceived. If you're the Grinch, you cannot be a kid's optician. You have to think like kids do. You have to be close to them, because before taking the recipe and making the glasses, you have to be in the heart of the kid, because otherwise you cannot do anything. And then you've spoken about something very important, the brand for an adult optician. But when you deal with kids, you have to deal with products, and it's different, because pediatric glasses have a function to fulfill. And then they can be recognized because of, logos or brands or whatnot. And all the rest is experience. But the contact with the physician, believe me, trust me, at times not many people trust me, but you don't need to talk with the physician or visit the physician. I mean, you can do it, you must do it if necessary, but the contact with the physician comes through the recipe. You have to talk with the physician based up and with the orthoptist, and often I talk more with orthoptists, but you have to work based upon the prescription, based upon the patient. So you have to convey your professionalism by talking with a professional. It's two cultures that come into contact with each other. If there is this contact, if you work well, if you do your work well, if everything goes well, time will prove to the other professionals that you as well are a professional. And this applies to everything in life. But specifically with kids, you have to work not based upon the brand, but based upon the product. Good luck. Break a leg. Hopefully you will pull down the walls. At the beginning, you always have walls to pull down. Okay, one last question. We've talked about families and prevention and an early diagnosis. So what is the main difficulty in engaging the families when we have an early diagnosis? The main difficulty is to explain exactly what are the next steps. So the parents receive a diagnosis all of a sudden, and they more often than not come to us with 1,000 doubts that they have not cleared during the visit with the ophthalmologist, the specialist. So on our side, we have a lot to do. We have to be able to provide a detailed and simple explanation of the next steps. We have to be self-assured when doing so. We have to explain the therapies, the follow-up, the alarms of worsening, when to rush to the ophthalmologist because there's something wrong, and when instead you can recognize an urgent case that is not extremely urgent. You have to invest time in communication in terms of education, and most especially with the patient, in this case a pediatric patient, and most especially also with families. Okay, thank you. One more question from the audience?
Abbiamo un microfono azzurro, eccolo qua.
The blue mic. Can you hear me? Yes, I can. More often than not, the industry, the opticians and the producers go to eye doctors to propose or try and establish dialogue. The gentleman is just repeating the question. And since education to me is the single most important thing, and in Italy the school of optics and optometry is not doing well, I'm wondering if it is possible for eye surgeons to go to opticians to deliver training, specific training about glaucoma. I mean, specific courses delivered by the pediatric eye surgeon, the orthoptist. More training, more education. I think this must be done by them. They should be the first mover. It's an interesting insight. I don't know if you agree. Also because we need to speak one and the same language. Whenever I've found an eye surgeon who's explained things to me, I'm on cloud nine. And I've explained to an eye surgeon how to use a certain instrument, but it should be something that they, start. Maybe I got it wrong. I don't think that the quality of the education of the schools in Italy is so bad. It's not uniform. Nothing is uniform. Every type of education in any area is not uniform. You can go to an excellent low high school, or you can buy a diploma. You can graduate at the Normale di Pisa or online. It's not the same thing. But other than that, I want to say something different, and then I will give the floor to the professor. I agree on an aspect that I noticed a long time ago, and this could be food for thought for all. I mean, objectively, I realize that we are speaking different languages. I mean, we are speaking about the same things, but we do so using different semantics, different words, and this is due to our background, because for physicians, everything that is not normal is disease. And for us, everything that goes beyond normalcy is called ametropy, but that's different. Oversimplifying very complex things, but I agree on the fact that we should learn to understand each other better, speaking the same language. It's not banal, because again, like I said, the backgrounds are very different in structure, but it's fundamental if we want to move forward in a better structured journey. Absolutely, because on the one hand, it is nice that you want to learn, because we as eye surgeons are always very active. I'm talking personally, but also others agree with me. We are ready to open up. We hold many events inviting opticians and optometrists, but education is also personal. You have to go for it, because I believe that there are already opportunities. The fact of saying that companies should come to us rather than to eye surgeons, that rather than, well, I don't agree on that. They should come to both. I don't understand why it should be exclusive. And as regards to the person who's trying to reach out to eye surgeons, I'm sorry if you didn't get an answer, because as a matter of fact, many eye surgeons are colleagues and look forward to collaborating and discussing. So never give up. Try again. Or go to other people through other channels, because there are many eye surgeons who are most willing. Good luck. Thank you to our speakers for your time, clarity, and depth, as well as emotions, as should be the case. Thank you all. Thank you. There is a cocktail in our lounge. Enjoy. We also have the photographer.